Hello, everyone, and welcome. I'm Ashley Harvey, Fellow for Life 2017, and I am the Justice Data Analyst for Open Justice Oklahoma, a program of Oklahoma Policy Institute. I would first like to thank the planning team that helped plan this webinar tonight, including Fellows for Life, Nyan Bergeron, Ekana Azinwa, Melody Cybrock, and Patrick Stanley. I would also like to thank the Chicago program staff for their help tonight, including the tech for this evening. That's Rebecca Ozaki and Maya Bauer, as well as the Tulsa program director, Rachel Gold. So tonight we had nearly 40 participants signed up to representing 9 different chapters and joining us from over 14 different states across the country. This webinar marks the 3rd in our Fellow for Life webinar series, which came out of our National Leadership Summit about a year ago. Many Fellows for Life expressed a desire for continued learning, as well as an opportunity to connect to the larger fellowship network. So the past webinars included one from this past January, featuring Patrick Stanley, Chicago Fellow for Life and Program Coordinator of Health Promotion and Disease Prevention at Rush University. The second was led by Dr. Sachin Jain, Boston Fellow for Life and CEO of Iora Health. And tonight we have Dr. Rishika Fernandopulle, who is a practicing physician and co-founder and CEO of Iora Health, a venture-backed national de novo primary care group based in Boston, Massachusetts. He was the first executive director of the Harvard Interfaculty Program for Health System Improvement and managing director of the Clinical Initiatives Center at the Advisory Board Company. He is a member of the Albert Schweitzer, Oshaka, Aspen, and Salzburg Global Fellowships, and is the co-author or editor of several publications, including Healthcare Policy, a textbook for physicians and medical students, and Uninsured in America, Life and Death in the Land of Opportunity. He serves as the Massachusetts General Hospital on the faculty of Harvard Medical School and on the boards of Families USA and the Schwartz Center for Compassionate Care. He earned his AB, MD, and MPP, that is Master's in Public Policy, from the Harvard University and completed his clinical training at the University of Pennsylvania and the Massachusetts General Hospital. Welcome, Dr. Fernandopulle. We're excited to have you.
Thank you. It's great to be here. So hopefully everyone can hear me okay. So thank you for taking the time to join. It's an honor and pleasure to be here. Let me make sure I get this done. How's that? Is that good, Ashley? All right, I'll assume that's good. So thank you for taking time to join. It's an honor and a pleasure to be here. It's a big heart for me to believe, but it was 24 years ago that I first, when I was a medical student at Harvard, was meandering in the hallways, and I saw a poster talking about this new thing called the Albert Schweitzer Urban Fellowship. And I'd done a bit of service work before I came to medical school, and I hadn't been able to figure out a way to sort of combine that with my life. So I was intrigued, and so I applied and was accepted as part of the second class. And as some of you may know, the Schweitzer Fellowship started in at Lamborghini years ago, but about 25 years ago, decided to start doing this in the US, and we were part of the second class in Boston. My project was working with a really amazing doc, a guy named Ross Neischuler, who was a doc at a place called Harvard Community Health Plan at the time. And what he did was actually started setting up a number of free clinics for the homeless, getting docs to volunteer in it. So I helped him expand the program, come up with a sort of manual to train people for unique conditions they saw when people were homeless. And through the work, it was clear to me that despite spending obscene amounts of money on healthcare, and I think any of us who've spent time in the US healthcare system know that we really spent so much money on it, the outcomes were actually really poor, particularly for people who are underserved. That experience was poor for patients. It was pretty poor for doctors too. Outcomes were bad, and we were spending too much money. I thought at the time the big problem with access. And at the time, it was partly true. There were 40 million Americans who didn't have health insurance. And I thought what we needed to do to fix healthcare was simply give them insurance. So I spent some time at the Kennedy School of Government and got a master's in public policy. And I started working on these sort of health policy things while I was seeing patients. Probably the most formative thing I did is I got the real cool opportunity to work with a medical anthropologist, a woman named Susan Sored, to really collect the stories of the people who are uninsured. We went around the country and we talked to people who are uninsured in a number of places in Massachusetts, in Idaho, in the Mississippi Delta, in South Texas, in Illinois. And we collected these stories and really we told people stories and then sort of talked about the policy implications. What it made clear to me, though, was that the problem, yes, we have to give people access to healthcare, but if we give them access to a crappy healthcare delivery system, we wouldn't really make an impact. The problem really, I sort of figured out, the thing I wanted to work on was how do we change how we actually deliver care to actual people, right? Because the goal is not health insurance. The goal is actually health. Health insurance is one of many sort of inputs to that. So how do we build a healthcare system that really focuses on health and not healthcare? And unfortunately, the U.S. healthcare system has turned into sort of a series of transactions. And you know, let me tell a story of a patient I saw that sort of illustrates this really well. And this is a patient I saw, and it was an interesting case because we had a practice in Boston that we had started to try and build a new model of care. And a gentleman came to me and he said, can my mom join your practice? But she lives in New Jersey. And I was like, well, why would she do that? She should have a doctor in New Jersey. And he said, yeah, but I don't trust those guys down there. Will you help me keep an eye on her? And I was like, sure. So she came to see me and she was a little old lady. She was in her 70s, very independent, driving to bridge games, a little arthritis, a little hypertension, but that's it. And was living independently. So I said, great, here's my card, call me if you need something. And a few weeks later, I get a call from this gentleman. He said, my mom is about to get a pacemaker. I was like, a pacemaker? Why would she get a pacemaker? She seemed fine to me. I don't know, will you figure it out? So I think, sure. So I pick up the phone and I call her. And here's the story. So she had gone to the bathroom a few weeks earlier and noticed a little red in the toilet bowl when she urinated. And so like a good doobie, she went to her primary care doctor. And the primary care doctor, you know, did what you're not supposed to. Didn't ask her any questions, didn't work it up. Simply said, red in the toilet bowl could be cancer. Let me send you to a urologist. So it goes, by the way, the most common cause of red in the toilet bowl is probably beeturia, probably ate beets the day before. Maybe she had a hemorrhoid, maybe she had a UTI, but this doc didn't work any of that up. So sent her to a urologist. Urologist, you're a hammer, the word looks like a nail, says, ma'am, this could be cancer. I'm going to do a cystoscopy, stick a camera up your bladder and take a look. But because you're in your 70s, I need you to go to a cardiologist to get clearance before I put you under anesthesia. So she went to the cardiologist. Cardiologist nurse does a review of systems. Ma'am, do you ever feel weak or dizzy? She's 75 years old. Of course she feels weak and dizzy. So yes, sometimes I do. Okay, nurse put a Holter monitor on her. She gets a Holter monitor on her, which monitors her heart rate. And so she gets her heart rate monitor, comes back the next day. He looks at, oh no, this is your heart rate goes slow at night, asymptomatic bradycardia at night into the 50s. You know, that could be dangerous. Nurse, schedule her for a pacemaker. And so I was like, whoa, whoa, whoa. Like, first of all, what happened to the red in the urine? Went away the next day. Probably a wild goose chase. Number two does she need a pacemaker? Absolutely not. Asymptomatic bradycardia at night is not a class 1 indication for a pacemaker. Number three is you look at her medication list and she was on a beta blocker. I was like, well, maybe we should just, which slows your heart rate down. Maybe we should change your beta blocker and we would be better off. So unfortunately, this is the U.S. healthcare system. We suck people down these sort of waves of needing more and more stuff without asking them what they want or need. And really, I think what I realized is that the system was based on transactions, document, code, bill. People get paid to do more stuff to people, not to actually improve their health. And we've created what I so think of as a medical industrial complex. It's $3.5 trillion a year. And it serves itself and not our patients. So my sort of little naive thing was maybe what we need to do is simply start over and rebuild the system, not on transactions, but relationships. And not just add stuff onto the system, but get rid of stuff. And we can build something new. So most things, by the way, we're trying to do to fix healthcare, whether you've heard of medical homes or ACOs, or they're all adding things onto the current system. And maybe what you can do is get rid of stuff to get back to the core. So I said, well, I'm a doctor. I could start a practice. let me actually just start over from scratch and build a new model from scratch. And said, if we're going to fix healthcare, we need to not go top down from the hospital, but bottom up from primary care, and let's build a new primary care model. And what if we changed everything? So started, in the beginning with saying, what's our job to be done? It's not see 27 patients and see them one at a time, do the best job I can, turn my brain off. It's that we have a population of people and they're a responsibility. How do we improve their health and keep them out of trouble and do whatever it takes, right? So that requires building a whole team around people. So it's not just us as doctors. What we do as doctors is tell people what to do, but the hard part is help them do it. And so we said we need a whole team of people, whether it's social workers, and we need to, and we really created this group of people we call health coaches. And they're from the community, they speak the language of the people they serve, and their job is to help patients execute on the plan. Actually, I don't love the word health coach. I have, unfortunately the name is stuck. I have a bad memory of a high school wrestling coach who said, sort of drop and give me 20. What the best word is what Paul Farmer, I'm sure many of you know, who started Partners in Health. He's done this for years in third world countries like Haiti. And he calls these people accompagnateurs, one who accompanies you in the journey to health. That's exactly who they are. And we have 3 of them per doctor. We put mental health and behaviorists in the practice and people with nutrition training, and we put people in the practice who are social workers. And that's really to help people fix their life, and that'll improve their health. We said we could interact with people not just in person, but by email and text message and video chat. We should go to their homes if we need to. We should, be proactive and not just reactive. We should have a huddle every morning where we sit around a table and talk about our patients. Not the ones coming in, by the way, but the ones who aren't coming in that we're worried about. We should help them manage them, make choices when they go to the specialist with the hospital. It's not a little different process, very different. We then realized in order to do this, we needed a different IT platform. We needed to, build our own system. The Epics and all these electronic health records are built to document, code, and bill higher, not do the right thing for patients. So we had to build our own. We had to build a different culture. And then the biggest thing you had to realize we had to do is we need a different business model, right? Because the current business model in healthcare, fee for service, doesn't let you do the right thing. And and most doctors, I think they say, well, I won't get paid for it, so I won't do it. And my attitude was we took an oath to serve our patients, not the insurance companies. So we should just do the right thing and figure out something else. The first thing we could do, the only thing we could figure out was that we would try and ask patients to see if they would support this. So we were one of the first what's called direct primary care practices in the country, where we asked our patients, look, we're going to do all this cool stuff for you, give you a health coach, take you for walks, free yoga classes, but your insurance is too stupid to pay for it. So the only way we can think about making it work is everyone paid us about $40 a month, which was sort of what you'd pay for your cell phone or your AOL at the time. We'll break even. If you can't afford it, pay us less. If you're rich, pay us more. And that crazy model worked, but then we realized, wait a second, if you're doing this, and we opened up a little practice in Arlington, Massachusetts, outside of Boston. We did that for 2 years, and then realized, wait a second, this is silly that we're asking people to pay extra money for healthcare. What we're doing by doing this better primary care is we're actually lowering hospitalizations and ER visits and cardiac caths and all that. The people on the hook for that should pay for it. And so we started going to employers, people like the Boeing company. We started going after low-wage unions, people like the casino workers in Atlantic City, the carpenters union in Boston, and said, why don't you pay this for your workers and we'll take care of them and they'll stay at work and they'll be healthier. And so we started doing that with the employers. And then about 6 years ago, we realized, wait a second, one group of people who benefit a lot from this are folks on Medicare. And so let's actually work with Medicare. A little like if any of you listen to Sachin Jain, who's a good friend, by the way. I never knew he was a Schweitzer Fellow. So I learned something new today. So like them, go after Medicare patients and get paid, again, through Medicare Advantage plans, sort of a fixed amount, and let us get on with it. So so we've been doing this now for almost 15 years. We a company called Renaissance Health, and about 8 years ago, ended up raising some venture capital money and created a company called Iora Health. By the way, we are doing this work as a for-profit, at least technically for-profit company. And happy to have a conversation about that. The mission has always been to transform healthcare. And by the way, the goal is not to build a company or to make money or even to build a medical practice or take care of tens of thousands of patients. So right now we have about 40,000 patients. The goal is to transform all of healthcare by shaming the system. It's the Southwest Airlines theory of change, right? So how do you, US Airlines in 1980, all probably too young, but they're very high fares, crappy service. And what changed? It wasn't, American and Delta and US Air waking up and deciding to get better. It wasn't the government. It wasn't the consultants. It was a new entrant, Southwest Airlines, coming in, doing something completely better, completely cheaper, letting customers vote with their feet, and that kicked everyone in the behind to get better. So that's what we're trying to do: is how do we change the whole industry? So we have now today 49 practices across the country. I'm in Houston this evening. We're just opening 6 of them here in Houston. We're in virtually every time zone: Boston, Atlanta. We're in Houston. We're in Seattle, Phoenix, Tucson, Denver. What's interesting about this is healthcare is local, right? So what you can't do is build the same thing and just stamp it out everywhere. You have to be willing to say what needs to be the same and what do we sort of do differently in other places. We have, like I said, we have about 49 practices now. We have about 40,000 patients. We have about 700 employees. And I think we're finally hitting a little bit of escape velocity. It's not easy. There are a lot of people in the sort of medical industrial complex who don't like what we're doing, right? Because what we do, we keep people out of the hospital, out of the ER, and that sort of threatens people. But it's exactly the right thing to do. People ask a lot, like, what is it you do that really makes a difference? It's actually fairly simple. So another story is we had a patient in a practice we ran in Atlantic City, New Jersey. And I was a doc there, and the health coach came to me and said, "Doc, the next patient's here. She is a hot mess." So I go in the room, and she was right. Her name was Joyce. She was a heavy porter, and she looked awful. She had sort of a blank look in her face. Her hair was all disheveled. She was in and out of the ER, in and out of work, not taking her meds, hypertension, had diabetes, not well controlled. So I was like, okay, let's try it. So we gave her a shared care plan, gave her a health coach, started coming to some groups. I ended up leaving that practice. I was trying to figure out, how do we open a second one? How do we scale this up? And 6 months later, I came back, and the doctor took over from me, Neil Patel. He said, "Rashika, that patient we saw the first week who was a hot mess? She's back. I want you to see her." So I was like, sure. So I go into the room, and I don't recognize her. She looks amazing. Her hair is combed, little makeup on, glint in her eye, back to work, no ER visits, diabetes, hypertension under control. And I was like, "Joyce, you look amazing." And she said, "Doc, I've never felt better in my life." And I said, "Well, Joyce, tell me what we've done to help you." What she didn't say is, "You're a good doctor, you have a good protocol, you got a good business model, you have a good IT system." Something very profound. She said, "You all cared about me. You taught me to care about myself, and I didn't want to let any of us down. You cared about me. You taught me to care about myself. Didn't want to let any of us down." And she was right. Right. That's the sharp end of the sword. It's this relationship-based healthcare. The problem is the current system doesn't really allow us to do it, particularly for the underserved, even FQHCs, because they're still paid in this fee-for-service thing. So that's what I think we're able to do by changing everything. So so I'm happy to take questions about that. I think, to me, a couple lessons. So one of them is, I started by being in sort of direct service business and say, we need to help people who are uninsured. We need to help run a free clinic. And I think that's all great. And it's a great place to start. I think if that's all we do, is simply put Band-Aids over the crappy system, the system will remain crappy. And it's not clear we're doing people a favor, right? And I think what we've tried to do at Iora is say, let's actually fundamentally change the system. Let's serve people, but do it in a way that actually kicks the system in the behind and maybe causes lasting system change. And I think that's sort of the thing we all need to be doing. There's so many big system problems that we need to stop putting Band-Aids over things. One of my proudest moments was actually last year. Mark Harrison, one of the CEO of Intermountain Healthcare, a huge health system in Salt Lake City, he gave an interview for Modern Healthcare, and he said, "I am petrified that someday someone like Iora Health will come to our market and start taking our patients away. We better start disrupting ourselves before they do." And they started doing what we're doing, right? Again, the mission is to transform primary care. That's exactly what we need. We didn't have to do any of it. We just had to scare them into doing it themselves. So that's sort of what we're doing. The second thing, which I said I'd talk a little bit about, and happy to have sort of much deeper conversation about it, is just sort of thinking about having done this for such a long time, the the personal sort of side of this, right? So I've been doing this for 25 years now, 15, without a day job, right? There was a moment where I quit the day job, didn't take a salary for 2 years, tried to start a practice, took second mortgage on the house. And while that, have been married and stayed married, have 3 kids who are now teenagers, shockingly. And so one of the questions I think all of us wrestle with, we're trying to do good work, is how do you balance that with the personal life and other relationships? I certainly don't pretend to be an expert in any of this, but I think it's the right question to ask, because I think having a balanced life is actually really good. B, it's really hard, and requires some planning, right? We do a lot of planning on our career side, but too often we sort of let the personal stuff happen. And I guess a few thoughts. One is that all of these things, one's life, one's career, is a marathon, it's not a sprint. Anything worthwhile you do, it's going to take years, if not decades. Like I said, I've been doing this for 15 at least. Find your life work. That's really important, and keep doing it and stick with it. But remember, it's a marathon, so take time off, right? The problem is not going to go away. The problem will still be there when you get back. Take time off. I think when I've run one marathon in my life, and only way I survived it was doing what I think a lot of people are doing now, which are called run walks, where you run for part of the time and then you walk, and then you run and then you walk. And I think that's actually the way to think about these things. There are times you're going to be running flat out, and you won't have time for anything else, but you have to find times in between where you walk a bit. The second is really, I think particularly if you have any sort of a life partner, to make sure to know what they're signing up for and have realistic expectations, right? You have to be on the same page about this. One interesting question, which we've talked about, my wife and I, is about how much do you share? And in one hand, like, you want them to know what's happening, but in some ways sharing too much, doing these sort of startup-y or these sort of new efforts, you go on these up and down roller coasters. And I think, you as a person doing it may have the stomach for it, but your partner may not. So we have this sort of agreement, tell me the really big things that are either good or bad, but the little up and downs, like, maybe I don't want to know about it. I think setting limits is really important. It's important to work hard, obviously, and I travel a ton during the week, but I sort of set limits on weekends, and I do not do work on weekends. If people ask me to do speaking engagements, I typically say no. I think everyone's got to figure out your limits and just stick to it. And then the other one, I think, is not feeling guilty about advocating for yourself and making sure whatever you do, you figure out a way to pay yourself enough, right? I think, again, no one gets rich doing this sort of work, changing the world, but I think it's okay to say I'm not going to be really poor doing it. And, I want to make sure, for us, my board says I need to get paid enough to be able to not worry about it, to be able to do this great work. So I think a lot of us doing this don't self-advocate enough. And I think it's important. So I hope this was helpful. I wanted to leave a ton of time for questions or any sort of discussion people may have. So I will stop there and take any questions that we may have. What's the best way to take questions?
Yeah, I just wanted to let everyone know that you can type questions on the side there. There's a place to type in questions, and we could ask them for you. But I guess to start out, I can start out with a couple of questions while we wait for some to come in.
Okay.
So first of all, thank you for speaking, and that was really powerful. I know a lot of that really resonated with me as a PhD student and with a full-time job and 2 children. So a lot of it resonates. But as a fellow for life, so if a fellow for life was thinking of starting their own business, what are some key skills that you think are key for that, or to learn as a clinician turned business owner?
Yeah, so I think there are several, right? So one, probably the biggest skill I think, which is necessary, is refusing to take no for an answer, right? Because the world will often say no. So when we tried to start our first practice, we get all sorts of no's from people, and you just have to ask a different question and just keep pounding away. And all sorts of people. One of the best advice I ever got from a high school guidance counselor was, there are people going to tell you that you can't do something. What they really mean is they can't do it, right? You can do anything. And so it's just, so it's don't take no for an answer is number one. Number two is it's just do it, right? Just get started. I think all of you who are Fellows for Life are well educated and, smart. And, and I think in some ways, the worst thing that happens, it doesn't work and you've learned something and you can try something different. And you just ended up better than you were before. None of this is irreversible. I think, I think this day and age, there may have been a time when, failure was a bad thing, but now I think people have a lot of respect for people who are willing to try to start new things. And almost everyone who's tried new things fail at some point. And you don't, if you're not failing, you're not trying hard enough, right? So I think skill two is, it's just do it, start it, and that's how you learn. And maybe the last one is not worrying about pissing people off, right? In some ways, I often think, like, if you're not upsetting anyone with what you're doing in life, you're not changing anything, right? You're sort of going along. And the world has so many big problems that need changing. And unfortunately, there are so many people benefiting from the current status quo that you almost ought to find things to do in life that you're upsetting a few people, and that's okay.
All right, well, thank you so much. It looks like we're still waiting for some questions, so I'll go ahead and ask another. So who are your biggest mentors throughout your career, and what do you think makes them a good mentor?
Oh, great question. So I've been really lucky to have some incredible mentors. And I think what's great about them is one, obviously they do amazing things in their life, right? And just inspirational. And number two is have been willing to take time to talk to me, right? And spend time with someone like me who's trying to do something, related or different. So, so two of my biggest mentors who people might know. So the first is Don Berwick, who some of you may know. Don was, he's a doctor, and he was head of a group called Institute for Healthcare Improvement. And then he was actually ran CMS, the Center for Medicare Services, for a while. And he ran for governor in Massachusetts. Just amazing guy. Another one is Paul Farmer, who I mentioned. He's someone who started Partners in Health, really was way ahead of his time doing things. They got David Blumenthal, some of you may know I worked for. David was a professor at Harvard, now is running the Commonwealth Fund. But they were all people who sort of helped me sort of get to where this is. And by the way, I think all of us have maybe an obligation, but I think we ought to be all trying to help people who are below. That's none of us are going to fix the world by ourselves. We should do what we can to change the world. But then if you can actually mentor and bring other people in, like that's the way to be a force multiplier.
Okay, great. Thank you. I'm trying to read through here.
That's it. So I see a question in the chat box here about
Okay.
Nurse entrepreneurship.
Mm.
Do you want me to read that?
As a new NP interested in primary care and preventative medicine, what advice do you have to implement some of the things you have talked about into a traditional primary care setting? Even if we cannot change the practice overnight, are there any small steps towards being a better provider in this environment?
Yes, great question. So I think we've learned a ton of things. So the whole point of starting Iora was we need to create the vision of where we want to go, right? And if we don't know where we're going to go, how we're going to get there, that doesn't fix healthcare, right? I mean, again, I told you we have 40 or 50,000 patients. What we now need to do is take the stuff we're learning in places like this and how do you apply it to the vast majority of people in typical practices. So I think there are at least a bunch of things that we're doing that could be useful. So I think the huddles we do are really important. So every morning we get our whole team in our primary care practice. We get the whole team together. Now we do it for 45 minutes. In a typical practice, you could never spend that much time, but I think even 5 or 10 minutes, get everyone together. It builds teamwork. Everyone's around a table, have a little teaching topic, and then talk about even one patient of yours, and not someone who's coming in that day, but talk about one patient who's not coming in, who someone is worried about, right? So we have a thing called a worry score and a worry list, and these are people we're worried about, and just to get other people's help on, hey, I'm really worried about this guy. He stopped coming in. His diabetes is out of control. His wife just died. What do you think we should do? And get other people's input, and then make a plan and do something about it. So I think doing these huddles, everyone can do. And it's hugely, a lot of great companies, the Ritz-Carlton, Southwest Airlines, a lot of great companies do that. It's, every day, get in that rhythm, get the team together, figure out what's of high value to do, and do it. Another thing we do is that everyone could do is I think being able to communicate with patients outside of visits is really important. It's ridiculous that we make people come in 2019 as largely the only way that we can interact with them. And so you're playing with little text messaging, a little emailing, a little video chat here and there. Get people to sign HIPAA waivers, and it's fine. Just use regular stuff. You don't need fancy equipment. I think that completely can change things and make practice better for everyone, better for the patients, and better for the docs. The third thing is really, I think a lot of people are doing this, really just start tracking your outcomes and seeing how you're doing on things, whether it's diabetes control, hypertension control. I actually think the thing we should start tracking is not those things. So those are all things that we, as health professionals, care about, but ask patients what they care about. The two questions that we ask all our patients is, how do you think your health is? And then the John Watson question, which is, how confident are you in managing your health? And I think, ask it, see where the people are who, well, obviously if you do it 2 by 2, the people who are in the bottom quadrant who think their health is poor and have low confidence in improving it, those are the ones that you ought to really focus on. And then you can start tracking it. Are we able to get people up, right? In some ways, if we can get people's self-efficacy up, then a lot of good things happen. So that's another thing I think that almost any practice can do.
Okay, thank you. The next one says, perhaps the most fundamental assumption underlying the Schweitzer Fellows programs is that most people enter the health profession training with enormous idealism, but our schools and then professions fail to encourage and deepen that, more often almost actively discouraging it. Can you offer some thoughts about how your experience as a Schweitzer Fellow helped you find the path you are on, and how the Albert Schweitzer Fellowship can be most effective in supporting idealism in action today?
Wow, great, great question. I think it would be a lie to say that I did what I was doing because of, school and the institutions I was in. I think sort of did it somewhat despite all of the above, right? And again, I think the problem is there are a lot of good people in our schools and institutions, but unfortunately, the institutions themselves have, I think, have a little lost their way and are too focused on the wrong things, as opposed to sort of what they should be, which is actually changing the world, right? We've been granted this amazing thing with society, and we ought to be using it to try and change the world and not just self-serving ourselves. I think one of the powers of the Schweitzer Fellowship is the collective, right? A lot of these things are really hard to do by yourself. But I think to the extent that you have other people working with you, that's really powerful. And I think what the really cool thing about the Schweitzer Fellowship is these are people who are not just in your field, not just doctors, not just nurses, but you get to work with people across the spectrum. And I think those sorts of teams are really, really powerful. So a lot of what we do in our practices is try to recreate that, because we think that's what really causes change. So one is it helps you get other people who provide support and other perspectives. And then I think eventually you can get enough people to try and create institutional change, right? To say like, hey, we need to do things differently. So I think it's really hard, but I think it's doable. And I think to sort of do it together, this great Margaret Mead quote that, never underestimate the power of a small group of concerned citizens to change the world. Indeed, it's the only thing that ever has, right? It doesn't need to be a big group. Just a small, dedicated group can make a lot of change. So.
Thank you. That's very inspirational. The next question says, I have deep respect for entrepreneurship and entrepreneurship. My DMP project was on nurse entrepreneurship. Do you partner with NPs in states that allow for nurse-led or independent practices? We have several nurse-run clinics in Alabama.
That's great. So we do have several NPs who work with us, who some of whom run their own practices. And as you said, this varies tremendously from state to state how it's allowed. And so we have so we do that in several places. I think one of the I think to be a doctor, you need to get a ton of clinical experience. I think a lot of NPs who come out of NP school, I think sometimes don't have enough clinical experience. So what we found is we need to get folks who've had enough clinical experience to be able to do that and really practice independently. So I think as a NP coming out, and it's by the advice for every clinician coming out is go out there and get some real experience. Because then that allows you to do these other things and practice independently. So we do in several places. We're not in Alabama yet, unfortunately. We're surrounding it. So we're in Georgia, we're in Atlanta, we're in Houston, we're in North Carolina. So we're closing in on it. But I think these sort of models can work with really anyone, and lots of NPs are really good at it.
Next, we have a question. Do you have some specific examples to share of how you have self-advocated before?
Yeah, no. So I think one of the things is, so as I mentioned this, like a lot of small companies, I have a board, and our board of directors decides how much they're going to pay me, and and I think there was some self-advocating. If you don't advocate for yourself, that I need to, look, I've got a wife, I've got 3 kids, I've got a mortgage, I've got student loans to pay off. Like I need to get paid reasonably for me to be able to do this great work. Yes, you could try paying me less, but that's going to be awful. And then what I'm going to have to do is start moonlighting on the side and doing all this other stuff, and then the work will suffer. So it's good for everyone if we sort of say, let's have it, this is not to get rich, but this is simply to pay the bills, right? That is what it is. And I was very transparent. I was like, here's what the bills are. This is what you pay for the mortgage, and this is what you pay for utility. This is how much I need to make. And this is what I need if I want to do this. And if not, you should find someone else to do it. And I think that sort of thing of, using some data, not being greedy, but saying this is what I need, and let's have that. I think in a lot of the contracts we design with health plans, same sort of thing. It's this is what we need, and here's why. And argue from principle, not. I think this sort of zero-sum game. I want to start with a really high number, so I'll get you down. That sort of stupid. And say let's talk about the principles here. Like we need to get paid enough to make this sustainable. Here's how much it is, and this is what it is. We're not trying to play games here, but we're advocating for ourselves strongly, firmly, based on principle, not on sort of greed or games or anything. And I think that works most of the time.
All right, our next question is, I am a first-year resident in family medicine. One of the things that has been so surprising now that I am in the field is just how heartbreaking lack of access can be. As someone who has been able to take this reality and create positive change, what were some ways you protected yourself when you were first starting out in the system that isn't always humane to its patients?
No, great question. So one of the things that I think is really powerful is, the privilege we get as clinicians to bear witness, right? So I continue. So I've been doing this a long time, and for a long time, people keep telling me, "Oh, you can't both run a business and start a movement and continue to practice. You have to stop practicing," and I haven't. And the reason I haven't stopped practicing is so I can keep experiencing exactly what you did. It is so easy once you sort of escape that to think that life is easy and that these things don't happen. And I think having to work with real people in real situations reminds us all the time that this is hard and that we have to do it. Now, let me get to the personal how do you protect yourself, but I think so stop doing it isn't the right thing, right? Keep doing it. Because this ability, because unfortunately, many of the people who you talk about who have all these problems because of poor access, they don't have a voice. And as a doctor or as a healthcare professional in general, it's actually amazing that we have a voice. So part of our job is to help bear witness. So a great little story again. I talked about Atlantic City. We had a whole bunch of maids we were taking care of, or cleaning the hotel rooms, and they would get a ton of back pain, right? And you ask them like, why back pain? And they said, oh, it's really simple because our jobs suck, right? So they, so for instance, they said we have to bend over. We have these short handle tools. We have to bend over the toilets, and it really hurts our back. If we could only have like a long handle thing that would work. I was like, why don't you tell your bosses that? No, they don't listen to us. We're just Hispanic maids. They don't even speak our language. And they said, oh well. The other thing is, we each one of us gets 8 rooms to clean, and we have to like lift the mattress and stick the sheets under it. But what if 2 of us could clean 16 rooms? It'd be so much easier. One could hoist it up and not have to bend. The other one could do it. I was like, why don't you tell your bosses? Same answer, because we're Hispanic maids. They don't listen to us. They can't speak our language. So I called a meeting together of all the casino worker owners. I said, you idiots are spending $2 million a year in back pain. Here's some simple stuff that you could do to avoid the back pain. And this is your money that you could save. And tell them what you just told me. And they said it. And they were like, of course we should do that. Right. So I think there's a real power of us as medical professionals to bear witness. Now, to get to your question, how do you keep from getting burned out from it? I think that's hard. I think I think you have to keep. That's why I feel like I have to try and help fix the system. I feel like if all I did was sort of see patients one after the other and try to put my finger in these dikes and not change the systemic thing, that would be a problem. Right now, the problem, by the way, with spending all your time just trying to change the system things is that it takes too long to show an effect. And so you get burned out from that too, right? The nice thing about seeing patients is there are things you can do today to make them better. And they can say, thank you, you helped me today, doc. So I think for me, this sort of spending a life where you spend part of your time clinically active, but part of your time, advocating in some way, anyway, is a nice balance. And so you feel like, I see it, I feel the pain, I'm going to bear witness to it, and I'm going to try and do something to fix the root cause of at least some of this. And if everyone did that, we could help fix the system.
All right, great question and great answer. Thank you. The next one is, how did you build the team that made Iora possible?
Yeah, it's taken a long time. I was 10 years old, but before that, I had this company called Renaissance Health for about 8 years after that. First of all, it is unbelievably important to build the right team. It is maybe the most important thing you do is to build the core team. And the way you build we have 700 and something people at Iora now. We'll be at 1,000 soon. But the way we build a great 1,000-person organization is you get the first 2 right, then the first 10 right, then the first 100 right, etc. Right? So it is the most important thing you can do. It's to build a team around you. A mistake a lot of people do is they try and build teams of people like them. And that's maybe comforting, but it's not useful. You have to get people who are not like you, who can complement you, who are good at things that you're not good at, right? Whether it's personality-wise, talent-wise, skill-wise, background-wise, etc. So, and you just have to make sure that they're people you absolutely trust and are completely aligned with your vision, your timeline, the mission, all of those things. When you find them, that's the way you change the world. So, so this was mainly personal relationships. So if you look at our Iora sort of core team, we have a group of a dozen of us who've been together since the very beginning for 9 years, who've been sort of fought through all this stuff together. Some were, we have summer docs. We have a guy, Andrew Schutzbank, who came to me as a third-year resident and heard about what we're doing and wanted to come do an internship, and then sort of stayed and has spent his whole career really after residency at Iora. We have our chief operating officer is a guy named Xander Packard, who I'd worked with before in a different job. who's our chief operating officer, sort of MBA type, and it's been awesome. What's interesting, there are people. There's a woman, Sonia Milsom, who I'd met at a conference. She had within a panel I was on, and I just said, someday we're going to work together, because you just find people like that in life, and you just file it away. And then 3 years later, we had an opening. I called her up. She said, Sonia, remember I said someday I want us to work together? I've got a way we can do that. Do you want to come work here? Right. So it's play the long game, and be really careful about how you build a team. It's the most important thing, and then it makes your life 1,000 times easier. So, and the last thing, just values matter a ton, right? I think the other thing mistake people make is they spend too much time worrying about sort of credentials and all that, right? Fine. Lots of people with skills and credentials. You want people who got the right sort of values and culture. That's the part that makes these things work well.
Yeah, I think there's a few up. Scrolling through the questions, sorry. So this one looks like it says, I just graduated and am now teaching quality improvement in an MSN program. We're having issues getting buy-in for units, designating someone to oversee this and sustain it. What can we do to sell this idea? We can't change if we can't get dedicated resources so we can track outcomes and build sustainability.
Yeah, no, great question. Several thoughts. So one is this sort of idea of tracking data and outcomes is really, really important. I think at some point, good intentions are really important, but at some point, then they're not good enough, right? So those good intentions have to translate into we are making an impact that's measurable on something that someone cares about, whether it's outcomes or satisfaction or cost or whatever. So it's really important we track these. It takes time and money to do that, right? And I think you're right, you need dedicated resources for it. And the word sustainability, I think, is really key. There are too many examples of well-intentioned, largely grant-funded sort of programs to do these sorts of care delivery changes. And then the problem is the second the grant runs out, everything goes back to the way it was, right? Which is not helpful. Not helpful for the patients, not helpful for the people working in it. So I think the goal has got to be sustainability. Our sort of belief is we're happy to take sort of grant money, philanthropy money, et cetera, to get things off the ground in order to track things and prove outcomes or develop a business model that will then make it sustainable, right? So it's sort of staging it. So I think in the beginning, you have to be just creative and hustle, right? So whether it's a grant or whether it's finding a champion somewhere and say, this is what we need, but then thinking really carefully early on of what are the things we're going to need to prove in order to make this sustainable, and how are we going to do that, right? And I think part of it is this idea of having to change the business model. Now, the good news is that the world is changing. So the fee-for-service world, which has paid more for doing more stuff to people, is starting to unravel, and there are more and more pockets. Again, it's not widespread yet by any stretch of the imagination, where people are saying, pay me for value, right? I want to get paid for better outcomes. And then that allows us to do some of the things that we're doing. So I think the good news is the world is getting better. Start by being scrappy, and whatever you need to get going, but then be really cognizant and try to plan ahead about what we need to prove in order to make it sustainable.
Okay, the next question is Iora Health an organization that helps with setting up nonprofit community clinics, or is it something different? I'm working towards establishing one and wondering about resources that are available.
Yeah, so for now, what Iora does is we just build these clinics ourselves, right? So we partner with either, again, our model is we have to get paid differently. And so we partner with people who can pay us differently. Either it's sort of, and we want to serve low income, high need populations. So we work with folks in Medicare, a little bit in Medicaid. We work with self-insured employers of low-wage workers. I mentioned the Carpenters Union, the Hotel and Casino Workers Union, and we just set these up ourselves. So we are not at the moment sort of helping other people set up clinics. I think we have sort of toyed with at some point in our history or in our future that we would we would do that, because the mission is to try and transform healthcare. But for now, that's not something we do. We're happy, by the way, if people want to come visit one of our clinics and wants to learn from us. We're happy to do that. It's not a secret. And so if any of you want to do that, whoever asked the question can reach out. It's rushika@iorahealth.com. And you'll come spend a day in one of our clinics, and you'll hopefully learn something, and hopefully we can be of help. But we're not in the sort of consulting business at the moment. There are certainly a lot of people who try to help, and it's sort of a little state dependent. I know in California there are a bunch of agencies that help people with set up nonprofit clinics. There's in New York there are some groups that I know that do it. So it really depends on the local area of who's willing to help set these things up.
We have another question about books. So what books have inspired you on this topic that you could recommend to everyone tonight?
Oh, lots of great books. I mentioned Paul Farmer as one of my sort of heroes. It's a great book if you haven't read Mountains Beyond Mountains, written by a guy named Tracy Kidder, about sort of Paul Farmer's early days trying to do his work. I think it's very inspirational and incredibly easy to read. So that's a good one. There are a whole slew of books about, how the U.S. healthcare system is sort of failing. Some of the better ones, a book called An American Sickness by Elizabeth Rosenthal, I think it is. There's another guy, David Goldhill, who wrote a great book. Can't remember what it's called, but he about his experience with the U.S. healthcare system. Now, unfortunately, there are a lot more books talking about what's wrong with the system, and very, very few that talk about how to fix it. But those are good ones. Another a friend of mine, Marty Makary, Makary, just wrote a great book, again, about sort of the healthcare system, what some of its failings are. I think our book on the uninsured is a really good one. So it's a little self-promotional. Uninsured in America, Life and Death and the Opportunity. The stories are still very much real about sort of what it means to not have access to care, and why this sort of employment-based system we have in the U.S. is crazy. I think that's something, if you want to read, you could do that.
All right, thank you for that. I know you already gave us the generous offer to come and tour one of your facilities of Iora Health, but what are some other ways you think that we could, as a network, leverage our network of over 4,000 Fellows for Life to make a better and more powerful impact going forward? And what do you think that means? What does it mean to be a Fellow for Life to you?
Yeah, no, so I think what's really powerful about it is to have this network of like-minded people, right? So as I think all of us know, not everyone who we went to school with shares, at least to the degree that most of us do, the sort of commitment to changing the system and helping people who need the help, et cetera. And I think having people like that around is hugely helpful. It's helpful sort of psychically, but it's also helpful that we should help each other out. So I'll put a little plug in, by the way, that we're hiring a ton of people in a lot of different places around the country. And so if any of you would want to come be a part of Iora, we would love to have you. So you can look on our website. We have tons of jobs posted. It's nothing posted that fits in a place you want. Reach out to me and we can see what we can do. But I think it's using the power of the network to try and change things is really important. I think at some point we need to start harnessing this network to try and change some public policy stuff too. There are a lot of glaring public policy things that need to be fixed, and we should figure out how we can use our voices together to help fix it. And then the third one really, I think, is to help encourage other people, younger students, people we know, to sort of get inspired by what we're doing and join in, because we need lots more people to follow in our footsteps.
Okay, great. Thank you again so much for presenting tonight and answering so many really powerful questions. I know that I, for one, thought that your webinar was inspiring and very powerful, and so thank you again. And oh yes, and everyone, I wanted to just let everyone know that the next webinar is in the works, probably before the end of the year. And if anyone would like to help or get involved in that planning, to let me know, and to everyone else, stay tuned for updates.
All right.
Thank
Thank you all.
you, Fernandopulle. Bye.
Bye.